Hello, everyone. Thank you for joining us during this month's Mitigating COVID-19 in County Jails Community of Practice series. My name is Tyler Logan. I'm a project coordinator for Wayne State University's Center for Behavioral Health and Justice, located in Detroit, Michigan. I'm excited to share this space with our esteemed guests and experts this month as we engage in dialogue around COVID-19 vaccinations. Joining me in moderating today's conversation is our very own in-house expert, Dr. Alysse Wurcel. Next slide, please. Whether this is your first, second, or third time joining us, welcome and thank you for taking the time out of your day to participate in today's Community of Practice event. Next slide, please. So today's event looks a little different from our December and January Community of Practices, and that's because for February, we really wanted to dive deeper into the dialogue, the conversation of things. So we'll begin with having some housekeeping in Zoom per usual, but then we'll really dive into our panel discussion with the doctors that we have who will present and join us on the panel today. And again, that is Dr. Ank Nijhawan, as well as Dr. Simone Wilds. And both of them bring expertise in the infectious disease spaces, especially along the criminal legal spectrum as they work within their respective communities in that space. And then again, this conversation will be moderated by myself, as well as Dr. Alysse Wurcel, and then we'll conclude with next steps. Next slide, please. The slides for today's conversation will be made available on the CBHJ's website. All of this information will be promoted and published, and then we'll make sure that we send it out in a follow-up email to you all. This session will be recorded, and that will be available in the follow-up email, as well as will be available on the CBHJ's website. There is a Q&A chat box feature, so if you were not able to submit a question prior to this event today, you can do so during the event. And please, please, please don't forget to fill out the post-webinar survey at the very end of today's Community of Practice event. Next slide, please. And now, thank you so much for joining us again, Drs. Nijhawan, as well as Dr. Wilds. We appreciate it so much. With further ado, I'd like to just jump right into the conversation. And again, thank you, Dr. Wurcel, for joining me and moderating today's conversation. With that being said, first, let's address the elephant in the room. It's been reported that the US leads the world in COVID-19 deaths, as more than 500,000 people have lost their battle with the disease. Thankfully, there is still work being done around the clock as the Johnson & Johnson plan to roll out their one-dose vaccine may be sooner than we thought. The Pfizer and Moderna COVID-19 vaccines are both messenger RNA or mRNA vaccines. So I'm hoping you can tell us a little bit more about what an mRNA vaccine is and how this may differentiate from the Johnson & Johnson vaccine. And if we could start, please, with Dr. Wilds, that would be perfect. Thank you.
Thank you so much for having me. I'm really happy to be a part of this conversation. Everyone has been hearing so much about the messenger RNA, so I'll talk about that because that's what we're all getting these days. So there are two companies right now, the Pfizer and Moderna, and they have messenger RNA, which we use mRNA. And what happens with this technology, it's new to us for using vaccines, but not a new technology in the sense that it has been used in the past, but never on such a large scale. So what happens when you have a messenger RNA? I'm going to make it as simple as possible. When you have genetic material wrapped around in fat, and that fat gets injected into the cytoplasm of your body, not into the nucleus, which changes DNA, which is a big myth that I just want to quickly address. And what happens is, this actually teaches your body how to make the spike protein. And the spike protein is what is really important in creating immune cells, in creating immunity for our body. So just a very simplified version of what the messenger RNA vaccine does. And of course, there are two different types, the Pfizer, which we have to give every 21, which is a 2-dose vaccine given 21 days, and for the Moderna, which is 28 days. So new technology, but very effective and something that we're very happy to bring to the market, especially in this time.
Thank you, Dr. Wilds. Dr. Nijhawan, is there anything that you would like to add to that as well?
Sure. I think so. The Johnson, you asked kind of how is it different from the Johnson & Johnson vaccine. So as Dr. Wilds pointed out, the mRNA vaccines are the ones that are currently available. Johnson & Johnson is going through the approval process, so we hope that that will be available in the coming weeks. The way that one is different, it does not use the mRNA technology, but it uses a different virus called an adenovirus, which is not does not affect humans. And it is used as a vector, so a way to transport the vaccine into the body. And so what the benefit of the Johnson & Johnson vaccine is that it will be a 1-dose vaccine. So Dr. Wilds mentioned the other ones are 2 doses, either 21 or 28 days apart. This will be a single dose, which I think will be really key for transient populations or jail populations where people may have difficulty coming back for that second dose. One other thing I would mention too about important distinction is the storage. So the mRNA vaccine, particularly the Pfizer vaccine, needs to be kept at very cold temperatures and freezers below 94 degrees. So very, very cold. And then once it's out, it needs to be administered fairly rapidly. What's fortunate about both actually the Moderna vaccine and the Johnson & Johnson, it does not require, it just requires refrigeration. And so will be more convenient to administer. Those are just the 2 things I wanted to add.
Awesome, thank you both so much. As we continue to unpack the current 2 available vaccines, as well as the potential for the Johnson & Johnson vaccination, can you speak to the effectiveness or efficacy that these vaccines have and unpack what this means for our audience today? For example, is the vaccine preventative of the virus that causes COVID-19 completely, or only the serious impacts of that virus?
Do you want me to start with that one?
Yes, please.
Oh, okay. So, so what has been really exciting about both of the Pfizer and the Moderna vaccines is that they have a really high efficacy, so around 95%. And what we mean by that is that they prevent serious disease and death, which of course are the things that we are most worried about with COVID. What's not clear, they likely decrease acquiring the virus, but they don't prevent that completely. So you could still get infected with the SARS-CoV-2, the virus that causes COVID, but you likely would not get very sick from it. So I think that's important to point out, because it has implications for how do you continue to protect yourself and others even after you've gotten the vaccine. But I think that the main point I would take away is that they are very, very efficacious and very effective at preventing people from getting sick and from dying from coronavirus.
Thank you for that. And Dr. Nijhawan, is there anything that you would like to add to that piece as well?
I would like to add something, is that?
Yeah.
I'm sorry, Dr. Wilds, yes, please.
So just to add to what Dr. Nijhawan said, it's that very effective. But you know, she pointed out that there were 95%. So remember, it's not 100%. So in the meantime, for those of us that have been vaccinated, we have to continue to do the public health measures that we've been talking about, continue to wear masks, practice social distancing, wash your hands, avoiding large crowds. Really, until we get more guidelines from the CDC, we have to continue to do those things.
Thank you for sharing that. And that really expresses and emphasizes the importance of vaccines as well as additional mitigation strategies. So the vaccine, from what it sounds like, is effective, especially towards those really serious impacts of the virus. But to make sure that we're keeping safe from all angles, of course, washing our hands and still wearing our face masks, even once vaccinated, could still be effective. At this time, I'd like to also remind participants that you can submit questions in the Q&A chat box, especially as the conversation continues. If you have questions, please feel free to send those there and we'll filter them up to our panelists. I would like to now switch and allow Dr. Wurcel to jump in and ask some questions. Thank you.
Thanks, Tyler. So this is going to be sort of a two-part question. The first part is going to go to Dr. Nijhawan, the second part to Dr. Wilds. So as I go into the jails a lot to talk about the vaccines, a common question is who should get the vaccine? I actually might switch it on its head and say, is there anyone that you think shouldn't get the vaccine? So I'm going to switch it on its head a little bit and say, so to Dr. Nijhawan, is there anyone that you would say, no, I don't know if you should get this vaccine?
Sure, that's a great question. Most people should get the vaccine right now. So young children, it's not been tested. So the Pfizer vaccine has been tested in ages 16 and up, and the Moderna in ages 18 and up. So we don't yet have data on kids. Fortunately, kids don't seem to get as sick in general as adults with the vaccine, but there are ongoing studies. So hopefully they will be included in the coming months as those results come up. The other groups would be people who have known severe allergic reactions to any components of the vaccine. There have been cases of anaphylaxis, so like a very severe allergic reaction from the vaccine. So those would be probably the main groups I would highlight at this point, that I would not, that I would hesitate to give the vaccine to. Almost everybody else is eligible and encouraged to receive the vaccine.
And so in the jails, people say, well, if I have cirrhosis, can I get the vaccine? If I have asthma, can I get the vaccine? And if I have HIV, can I get the vaccine? So for those three questions, cirrhosis, asthma, and HIV, what do you say to people?
So in general, we don't have, because this is relatively new, we don't have years of data or randomized controlled trials in specific populations to say, oh, we know there's so much evidence in cirrhotics or people who have asthma or people who have HIV. However, there were people, for example, with asthma, there were people with HIV in the studies, in the randomized control studies, who did well with the vaccine. And so and people who have immunocompromised, have weakened immune systems, people with asthma, people are at higher risk of getting sick from COVID, really should get the vaccine. So of course, it's going to be a personal decision for every person, what their own medical issues are and concerns are. But I would vaccinate people with asthma, with HIV, with cirrhosis, with all of the above.
Thanks. And so now a follow-up question to Dr. Wilds. So Dr. Wilds, I know you're on the task force sort of advising how the state of Massachusetts rolls out vaccines, and Massachusetts has prioritized inmates or people who are incarcerated in jail. That has caused a lot of discussion. And I know, many different communities are discussing that prioritization. I wondered if you can just give us some thoughts on why the task force decided that way and your thoughts around that.
Sure. I will tell you that as a member of the advisory group, we've had a very difficult task of trying to prioritize different groups. But, it really has generated a lot of robust discussion to make sure that, we give vaccinations to those that are in greatest needs. And as we all know, we've had a lot of outbreaks in the jails and a lot of deaths in the jails. So when we were deciding as to who should get the vaccines first, we thought it definitely was something that we wanted to put at the top of the list after healthcare workers, correctional facilities, jails, nursing home, that particular group, because they've had a significant impact from COVID-19. So it was not even a very difficult decision. We all knew we wanted to do the right thing. And given the vulnerable population in this particular setting, we wanted to make sure we took care of them.
Thank you. So Dr. Nijhawan, do you mind going over some of the side effects that people might expect from the COVID-19 vaccine?
Sure. And I think that's one of the first questions that people ask. So some of it is the local side effects. So where you get injected. So typically people get injected in the upper arm. Very common to have arm soreness, maybe a little bit of redness, swelling. Usually those are most within the first day. But that those are common. And then, so that's local side effects. And then you think about systemic side effects. So things that affect your whole body. And sometimes people will have a fever, low-grade fever, they'll have chills, they have some muscle aches. Those are some of the most common, and fatigue, headache. Those types of symptoms are the most common that have been seen in the studies. And then also after recently the CDC published data on all the people who got vaccines within the first month of administering the vaccine in the country. And it was the same reports of these types of side effects. Most common in the first day or two. Majority of those are mild and go away on their own or with some over-the-counter anti-inflammatory medication.
Thank you so much for sharing that. We kind of talked a little bit about the effects of the vaccination and COVID-19 overall. I'm wondering if we can talk a little bit more about what the future would look like with PPE, proper protection equipment, and the overall new normal or our overall lifestyle once vaccinated. Is COVID-19 here to stay, or do we think that through vaccinations and of course through other mitigation strategies, we may see another normal again?
So I will start with that question. I think right now, I mean, we're definitely going to continue to do what we're doing. As we get more people vaccinated, I think that more than likely our styles are going to change. We're going to have a new normal. And, we're still trying to figure out what that is going to look like. But I anticipate that we'll be wearing masks for quite some time. Don't want to give any date, but I think that, we'll have to continue doing that until we get to what's called herd immunity, when we have enough people vaccinated, either by the vaccine or by the infection itself, that those that didn't get the vaccine are protected. So we're not quite there yet. So we'll just have to continue on the path we're on right now.
Thank you for that.
There was a question in the chat box that I just wanted to bring up, and just to encourage people that we're going to answer their questions right away, and that we love questions. Sorry if you hear hammering, my husband's hammering. But there's this thing called the COVID arm. I don't know if either of you doctors have heard of the COVID arm. So someone asked about specific questions. Could someone discuss COVID arm that tends to be present days later because it's not frequently discussed? I've seen it a few times, but I don't know if Dr. Wilds or Dr. Nijhawan, you've seen it.
I have actually not seen the COVID arm.
Okay, good.
I haven't seen it either, but I think what you're describing is sort of what I've heard about is redness or rash, swelling of the arm that received the injection. And is that what you're talking about?
Well, the thing that I've seen is it happens about 5 to 10 days afterwards. And so it does cause it's being reported specifically with the Moderna vaccine. It's sort of like a delayed reaction. I don't know if that's what the person's talking about. I haven't heard it called the COVID arm, but it's sort of surprising. Everything seems fine. And then it comes back about 5 to 10 days after. But I mean, the short answer to that is it actually resolves. It's not a sign that anything went wrong with the vaccine. It wasn't, I don't know if it was really reported a lot in the trials, but in practice, I've seen 2 or 3 cases of it. Basically, people at the jail will get the vaccine and then a week later just send me a picture of what it looks like. And it actually goes away quickly and often doesn't really hurt. It's just sort of a local delayed reaction.
Yeah, that sounds a lot like what one of the attendees also mentioned in the chat. They said it happened to them about 8 days later, and that included extreme itching and a rash. So from the sound of it, it seems like those are just some mild symptoms that eventually go away after a few more days.
Tyler, can I just add that I would definitely tell individuals that if that happens after your first dose, you should still go ahead and get your second dose. It should not be any reason for you not to get your second shot when it's time for you to get it.
Thank you for adding that.
Someone else just asked a question, which I'll send to Ank. Can you discuss the variants? What is a variant? And is there a point where a virus no longer mutates?
Sure. Yeah, that's I think a really hot topic these days. So as COVID has really spread all around the world, there have been different variants that have come up. And what that means is that the virus does mutate, and mutates enough that it's a different variation of the original virus. And what this can mean, the ones that we know are clinically important, there's been one in the UK, in South Africa, and I believe in Japan, that they've had different variants that may have different characteristics, where they may be more infectious, meaning that they spread more quickly. There's some concern that some of the variants will cause more severe disease in people, so that when people get infected, that they're more likely to get sick. Then the question of is at what point is does the virus no longer mutate? So the virus that's what viruses do. They will continue to mutate. I think as more people receive the vaccine, and as if there's less COVID out there, and so then there's less opportunity for it to mutate. So there is a good argument to continue to really strive for herd immunity and for vaccinating people to eliminate this ability of the variants, more variants to come up. But there's no point where you say, oh, it's been, this many weeks or months, there's not going to be any variants. There's always that possibility, as long as the virus is out there and replicating, making copies of itself and growing. But that's all the more reason for us to try to contain the virus as much as possible.
A nice follow-up question for that is also in the chat box. Someone asked, if a person has COVID, should they still take the vaccines?
So I'll go ahead and take that. If you had COVID in the past, we definitely want you to go ahead and get the vaccine. And the reason is that, your natural immunity is going to wane after you've had COVID infection. And so, it's going to wane after, say, 90 days. So you're still going to need extra protection. So we definitely want you to get the COVID vaccine. What we don't want you to do is, if you have active COVID, we don't want you to go at that time to get your vaccine, because of course you're going to expose everyone else. So, the key thing is you have to be over the acute illness and out of isolation. Then you can schedule time for your vaccine. I know there's been a little bit of debate in terms of, do you wait for 90 days before you go get the vaccine if you've had COVID? I really think that the CDC guidelines really said there's no set time that you need. You just make sure you're not acutely ill and in isolation. So key point is get the vaccine when you can.
Thank you for that. Another question in the chat is, can you talk more about individuals that are reinfected even after recovering and receiving both doses of the vaccine? So I know earlier we talked a little bit about the difference in symptoms once you get vaccinated. The vaccine really helps prevent those severe and really harsh symptoms from COVID-19. Can you unpack that a little further for those who have this question?
Sure. So I think, when we talk about the vaccines having such high efficacy, it is really preventing severe illness and death. So it doesn't mean that you absolutely won't get the virus. And we have had reports of people who've received both doses of vaccine and still get COVID, get infected with the coronavirus. I think I would caution you and say that, this doesn't mean that the vaccines aren't working. In fact, they're working very well. When we give this to millions and millions of people, and we know it's not, is there a reason, are those people ill? But I also want to be cautious that we don't scare people from not getting the vaccine. So it can happen. The cases that I am aware of have been mild. But we have some more to learn, but I would not let that be a reason for people not to get vaccinated.
Thank you.
So a question that came up is there anything that you can do to help prevent the side effects following the shot? This person said, I was really tired. Will vitamin C or Tylenol help? And I'm also going to throw vitamin D in there in the question, because there's been a lot of talk about throughout COVID, I feel like vitamin D, vitamin C. So Dr. Wilds, I'll put this one to you. Is there anything to help prevent the side effects following the shot? Anything you can suggest?
I would say, definitely hydration. I think a lot of people who have been hydrated say they feel well after the shot. There's no standard guidelines other than like Tylenol or Motrin, that is fine. But with regards to the vitamins, I don't think there's any data that say they make a difference. For me, I tell my patients, make sure you're hydrated. And if you develop a fever or you have some body aches, some Tylenol or Motrin seems to work just fine. And the key thing is symptoms should resolve within at least 72 hours. So they're not going to last for a very long time. So don't be alarmed. And if they're lasting very long, make sure you contact your healthcare provider.
Then someone asked, could you speak about vaccine distribution among the jail versus prison population in states where inmates are receiving vaccines or those who are not previously infected prioritize? What does the rollout look like? I'm pretty close to this. I don't know if I might take a stab, but so I can say in Massachusetts, we are not prioritizing based on previous history of COVID. Yeah, we're definitely not doing that. If people make the decision themselves who are incarcerated that their history of COVID in their mind is enough to protect them, we counsel them about it, but we're definitely not prioritizing based on that. Some places started prioritizing people based on comorbidities. So they would have, a lot of the prisons and jails will have like chronic care lists. So they'll pull those people out and offer it to them first. We had a plethora of vaccines sent to our jails and prisons. And so we didn't have to do that. And in fact, I would say the best strategies have been going to a cell block and sort of setting up some sort of partition and asking each person to come behind the partition for some individualized counseling. And that way it potentially minimizes the sort of whether someone takes a vaccine or whether someone doesn't can be a very personal decision. And so that's one strategy we've used. The other thing is in some states, I know in Michigan or even in here, like the distribution of vaccines to staff members may be different than the distribution of vaccines to people who are incarcerated. So for example, in the prisons here, we have WellPath. WellPath did the vaccine distribution side to the people who were working there. And I think in the prisons, and then the vaccine distribution to the people who are in jails was done by and rolled out by the actual sheriff's office. So there could be parallel rollouts depending on who's doing the rollout. But that's been my experience, and I can speak to that, I guess, a little bit later on. Then someone asked a kind of a question, but I'll give it to Dr. Wilds. Does the vaccine protect against these new strains of COVID?
It's a great question that we hear all the time right now, especially given the variant. And the good news is that the vaccines we have right now do protect against the variant, but we have to vaccinate many people quickly because, as you know, the variant is moving quickly, meaning we're having increased cases. So that will affect how effective the vaccines are going to be. But take home, get the vaccine when you can, because we want to be ahead of the variant to make sure that we are ready for whatever is coming down the pike.
Thank you for sharing. There's also a question that says, I've heard speculations, sorry, it bumped up a little bit. Heard speculations from the health community on the need for COVID-19 vaccine boosters several months after majority of your jurisdiction's population has received the vaccine, reaching herd immunity. Have either of you heard discussions regarding the need for a booster shot?
I can feel that. I would say that the discussions around the booster have been mostly hypothetical. I don't think that has been studied, but there is some concern that, so say there are going to be variants to which the vaccines are not quite as effective. Does that mean that people who were previously vaccinated and now there's new variants are going to need to get another shot? That's the context in which I've heard it. I have not heard of this where once you have herd immunity that everyone would again need a booster shot. So I don't think that has been studied, but I have I know that as these new variants come up, that the companies that are developing the vaccines are trying to make sure that their vaccines actually are effective against those variants, and if not, trying to come up with solutions to make a vaccine that is effective. And in those scenarios, if we have new variants, we would maybe need another round of vaccines, but nothing that's been studied yet that I'm aware of.
Thank you. Dr. Wilds, would you like to respond as well?
I totally agree with what was just shared. Definitely, I would say more to come on that, because as the variants become more prevalent, then, you know, there has to be something to address it, but we're kind of waiting to see what happens. But the good thing is they can make changes quickly based on the type of vaccine. In particular, the messenger RNA vaccine, we can make adjustments real quickly if we need to do something for the next round of COVID-19 vaccinations.
Thank you. And really quickly, someone asked to define what herd immunity is. I'm sorry. Herd immunity is when a large part of the population is immune to a specific disease, and usually is accomplished through vaccinations. Another question in the chat is, does it appear that these vaccines will have to be taken yearly? I'll send that question off to you, Dr. Nijhawan.
Sure. Yeah, I think I don't have a straight answer to that. You know, and I think it's in the same vein. We're not completely sure what's going to happen. There has been discussion likening COVID to influenza, where you get to a point where maybe there's a seasonal variation, or that it gets to set a low enough level that, you know, we're able to go back to somewhat normal life, but that COVID is still around, and that we may need to get additional vaccines as we learn about the virus changing. But I think most of that is speculation. I don't think we know. I don't think we knew that a year ago that we'd be where we're at. So I think it's a little bit challenging to say. But I do feel I've been really impressed with the fact that we have developed vaccines so quickly that are so effective, and that as we learn more and more, that we would be able to stay on top of it. And if that means that we need to take another booster or another dose of vaccine, then, you know, so be it. I would be first in line for that.
Yeah. And then this next question asks, does the county jails and the Michigan Department of Correction system here in Michigan have the staff to administer vaccines? I'll briefly touch base on that. And then if the panelists on the call want to kind of generally touch base on that from maybe your respective areas, that'd be great as well. Here in Michigan, like many other states across systems, the jail system looks different, possibly depending on the county that you're in. However, there are definitely county jails here in Michigan that have staff ready to administer vaccines. I think, for example, Wayne County in Detroit, Michigan, utilizing the disease intervention specialist to do everything COVID-19 and contact tracing related upon booking. Also have jail health staff in addition to that, that would be prepared to administer those vaccines when available. What about in your communities, Dr. Nijhawan and Dr. Wilds?
So I work at our county jail, the Dallas County Jail, which is a very large county jail. We have up to 6,000 people there that are incarcerated there. In terms of administering the vaccine, I mean, we have full-time medical staff, and that's likely who it will fall to. Our county health department is completely overwhelmed with just their response to the COVID pandemic within the county. So we will likely incorporate, we do not have vaccine available yet in our jail. We are very much hoping for the Johnson & Johnson vaccine to come through because of what I mentioned before about the one dose, making it easier to administer. So we will likely use our existing medical staff, who granted are stretched very thin already because of COVID, but that will be our approach.
I'm probably going to have Dr. Wurcel answer that one, because she might have a little bit more experience in the jail here in Massachusetts.
Yeah, you know, one of the big concerns early on that I was really worried about was staffing. And I think what it was a concern, and then they just started doing it. They did have to pull nurses from other places. And in spots in which there was actually a COVID outbreak and vaccination happening at the same time, it was really challenging to staff both the testing and the vaccination. Now that we've come through, and I could say in Massachusetts jails, between 30 and 60% of people have accepted the vaccine, people who are incarcerated, which is incredibly high rates, that higher than I would have expected. I don't hear about concerns about staffing as much. But I do think as you try to roll out your vaccine programs, the sense of being really overwhelmed by the staff is something to hit up. Right. You know, you want your staff to feel safe. You want your staff to feel supported. There were some jails where people have done, you know, if you start doing 100, 150 shots a day, you're going to feel really drained afterwards. And I know in Massachusetts, a lot of the medical students had offered to go into jails to vaccinate. Historically, we've had nursing students go into jails to vaccinate. So that might be something to reach out to see if that could happen. Because the last thing you want is to have your staff overwhelmed and, you know, not being able to come into work, because it won't only impact the vaccination, it'll impact how your whole jail flows. So I think it's a really smart question. I can say, and it did impact us. Now we're through it and we're more on the trickle state of vaccinating rather than the full out. It's not as much of an issue.
There are a couple questions in the chat relating to those within congregate care facilities, such as jails and prisons, being moved up in the priority of getting vaccines. Can you talk a little bit about who should be prioritized, especially as it relates to the jail population?
So I will take
go ahead.
that. Just, you know, in Massachusetts, we really spent a lot of time in trying to figuring out the people that have been most affected by COVID and the locations. And so congregate settings was really something high on our list. And so when it was time to deliberate about, you know, who should get the vaccine first, it was an easy option for us in Massachusetts. And we put them phase 1 right after healthcare workers. I think it really depends on what each state advisory board is doing. I would suggest if your state does not have jails high on the list, that maybe you try to reach out to the advisory group and send them a letter and just explaining why you think it's important, because in jails, you know, it's very close quarters, easier for transmission, and definitely you can't social distance and very higher rates of outbreaks. So just share that with the advisory group. I think it will make a difference.
I would make a comment as well. I think, like Dr. Wild said, that this is very state dependent, and correctional systems are run very differently in different places across the country. I think, unfortunately, this has become fairly political, and so some places will not prioritize people who are incarcerated over other groups. And I know, for example, in Colorado, this became quite political, and other places. So I think, I feel strongly that people who are incarcerated in congregate settings should be prioritized, are high risk. If you have limited amount of vaccine, then prioritizing within that setting, those that have medical comorbidities. And, you know, we are obligated in jails and prisons to provide the community level of care. So if people with certain medical conditions qualify for the vaccine in the community, by law, we need to be providing that within the criminal justice system. I think on top of that, we have the risk of being in such close quarters, and what we already know has been really high rates of transmission and complications. So I would add that as an additional risk factor. But unfortunately, it really does vary by where you live and by some of the politics.
I'm going to just mention that I think Arkansas, when it originally came up with its plans, did not prioritize prisoners. And then there was a journalist who sort of went deep into that. And I don't know if it's just timing or coincidence, but the sort of day or two after the journalist's report came out about this, then the governor changed the prioritization. I think there's a misconception about how the infection with COVID protects you. And I think sometimes policymakers in jails and prisons, because so many people in jail and prison have had COVID, have felt that it's not a good place to put it. I also think there's a misconception that because of a history of atrocities and mistrust that goes on in prisons, that people in jail won't accept the vaccine. So I think the Massachusetts experience, I know we're not everywhere, can say that, you know, with the proper, really intensive education, people in jail, people who are in prison want this vaccine. So it's not, from my experience with trying to get people to get vaccinated for the flu in the jail, it's a very different experience than I'm having trying to get people vaccinated for COVID. And I worry that sometimes the decisions about prioritizing people in jail is that, well, they're not going to want it anyway because they kind of don't trust us, and they're going to want to wait until the outside. And the reality is the experience has been very different than that. And so everyone should at least be offered it. So just some thoughts about that. Simone, I'm going to ask, this is a question that comes up a lot, Dr. Wilds. What percentage of the population determines herd immunity?
I know that number keeps changing all the time. I think the standard is 70 to 75, meaning you need to have that amount of people. But you know, one thing I would say, the more people you would have that you can get to herd immunity, the better it is. So, you know, I know Dr. Fauci has kept changing the target. And so the key thing is, though, we want to get as many people vaccinated just to make sure we can protect everyone that didn't get it, so that, you know, we can get back to whatever our new normal is going to be.
I just wanted to comment on the operationalization of vaccination if someone's released after the first dose, because that was originally for the Massachusetts jails. They were only going to offer vaccine to sentenced people because they were concerned that that was the time you could assure that someone would get the first and the second. But with some work, we encouraged people to offer it to everyone. And the way that works in theory is if someone's released, they're allowed to go to any mass vaccination site, and the computer system will have their name and that they received the first vaccine in that, and that is a ticket to get the second vaccine. They will also have their little white card but if it's lost, there's documentation. I am worried that's the utopian, you know, Willy Wonka world of it all. I think the reality is one that people who are released may not be able to prioritize or get to their second vaccination, that they may, you know, because of ID issues or other access to scheduling on computers, not be able to do it. So I think it is challenging, and I agree that the one dose is going to make it a lot easier and to avoid that. And then I'm going to ask Dr. Nijhawan, there have been some discussions regarding the vaccine's effects only lasting 3 months. So do you mind just commenting, or what do you think about that?
Yeah, I think people have been concerned about how long the vaccines are going to last, but I don't think we have any evidence that they only last a certain period of time. We don't have long-term observation of people who got the vaccine beyond those studies. Also, one thing that may complicate things is people that were in those studies, people were randomized, right, to receive the vaccine or not, to get the placebo. And now people who didn't get the vaccine, who are in those studies, they want the vaccine. So we may not have that much long-term follow-up on people who didn't get vaccinated, because people are going back now and want to be vaccinated. But I'm not aware of it only lasting a certain time period. They have looked, you know, what they're looking at in these studies is what, you know, how are people's levels of antibodies, and people's antibodies are very robust. The level of antibodies are really high to COVID after they get vaccinated. We don't know for sure, you know, what level does it need to be for people to stay protected. And as we said, the vaccine is not 100%. But as far as we know, they're effective and relatively long lasting. We don't have enough experience to say exactly how long that is.
I'd like to just quickly add here that as the conversation continues and we get closer to our 2 p.m. Wrap up, please feel free to still submit your questions. Whatever questions that we do not answer during today's session, we'll answer and send in the follow-up email so that you still have those responses provided as well. The next question here is, how were scientists able to come up with the vaccination so quickly? So if we could actually, if I can add to this question, can you walk us through maybe what the process looks like for creating the vaccination? And that's open for whoever would be willing to answer first. Thank you.
So I'll start. We're all in the pandemic. We've seen a lot of lives being lost. And so we needed to do something aggressive to try to save lives, get people back to what they're accustomed to. And one of the things that we can do in this setting is we can create vaccines. And, with the pandemic being everywhere, we were able to get people to collaborate, to share ideas. And along with that, we got a lot of funding. So there was money being poured into the research, to supplies. So that really makes a huge difference when we're trying to deal with something on such a large scale. I know in the past, vaccines usually take such a long time, but in this case, when you have funding and you have the resources, it really makes a big difference. And so, that's what happened in this case. They had the messenger RNA technology that they've used in the past, and they just really amplified that. And they were able to get good preliminary results. You go through phase 1, phase 2, phase 3, initially in the lab, and then you start testing it on individuals. And so, we're able to get results partly too because we're in the midst of a pandemic. So you have more people that are able to volunteer that actually have the infection. So, I think combination of things really work together, and we're able to get vaccine in rapid time. But I must point out, it doesn't compromise the safety. The FDA has really made sure that, proper protocols are being followed. So that was not compromised in any way.
Thank you for sharing that. Dr. Nijhawan, I'm sorry, Dr. Nijhawan, would you like to also add to that?
No, I think what Dr. Wild says was exactly right. I would also say that people stopped doing everything else. I mean, this was the main focus for all of these pharmaceutical companies. There was a lot of public-private collaboration between the National Institutes of Health and pharmaceutical companies in ways that are really unprecedented. But everything else was put on hold. This was everyone's main focus. And with a lot of the science was already existing. And so this really just expedited that.
I'm going to jump in there and just say in jail yesterday, I was seeing a patient with HIV who expressed a lot of sadness about COVID vaccines being able to be done so quickly when they were, living with HIV. And it was interesting trying to he's like, what would it take for me and my community to be a priority? And so I don't know, for those of you that are going to talk with lots of different populations, I think that's something that people might ask, like why, which you've answered, but it is interesting to think about it in context of who was affected. So just something I wanted to say there. Dr. Wild, someone's asked us the mRNA vaccine is safe for pregnant women?
I think that's the most popular question ever because everyone wants to know, if I'm pregnant or does it affect my fertility? And, the answer I say is, this particular group was not involved in the trials that were done, but based on the information that we have right now, the American College of Obstetrics and Gynecologists, they are recommending that pregnant women get the vaccine. And part of the reason is when pregnant women get COVID, they get very ill, or they could get very ill, meaning, they need to be on a ventilator. Their breathing is really compromised. Sometimes they have to go, they're going to labor. And unfortunately, sometimes they die. And so based on those risk factors, we think at this time it is safe to get the vaccine. And also remember, it's not a live vaccine, so it's not going to really change your DNA as people suspect. So it is a safe vaccine. But I do counsel my patients, make sure you have that discussion with your healthcare provider so that you can be in one accord on that matter. And just a quick point about whether it affects fertility. I think that's really misinformation, false information that's been circulating on the internet that we really want to dispel. There is nothing that says this vaccine is going to affect your fertility or cause impotence. I just want to make sure that everyone is aware of that.
I would also mention there were 23 pregnancies in people who were in the vaccine arms of the studies and no bad outcomes. There was one person who had a pregnancy loss who was in the placebo arm, but there's really nothing to indicate that this would affect fertility or pregnancy.
There's another question in the chat here that asks, how do you determine which prisoners are released due to high risk? So a lot of that comes from guidelines that are sent down from individual organizations such as the CDC, for example, and that relates to those who may have pre-existing health conditions. We've just briefly talked about women who may be pregnant in this system. They also fall under that category, those who may have been older age. So really, if you were more susceptible to contracting the virus that causes COVID-19, you were at risk or high risk for actually developing the disease. Is there anything else that you would all like to add to that, Dr. Wurcel, or either of our panelists?
I mean, it was in March, April, and May, there was a push for decarceration, and, you know, I think it was overdue. And I think decarceration, at least in the Massachusetts jails, helped us, was very useful in being able to socially distance as much as possible. And so the push for decarceration was prioritized for people that were on, you know, cash bail, things like that. You know, it is, I think that was what happened back then. I have seen some things come, some letters, or my patients ask for letters. I don't know if it has as much, now that there's a vaccine, now that there's a lot of other more treatments, a lot of other, I don't know if that still exists as much. I don't think it's still at play as much in Massachusetts that having comorbidities is a reason. I know people are still using it. I don't know, Ank, if in Dallas what was your experience with decarceration?
Well, not to harp on the politics, but I think we're in very different political environments, and there was not much appetite for decarceration here. And there have been multiple legal battles that were actually ongoing with the ACLU and the criminal justice system prior to COVID. And I think COVID has just really highlighted that in it, you know, there are people in jails and prisons, particularly in jails, who, you know, that it discriminate against poor people because of the cash bail system, et cetera, that really don't need to be there. And then on top of that, we're putting them at risk for a potentially fatal illness. And so I think it has just highlighted how broken these systems are. Unfortunately, I can't say that that's overwhelmingly turned into action, but it certainly has prompted a lot of discussion. I think that it also points out the challenge that as a medical provider in this setting, you know, I may have my medical opinion, I may have my public health opinion, but ultimately I don't decide who stays in a jail or who goes into a jail. And so we can advise the sheriff's office and our custody colleagues, but, you know, I don't have the legal background or the, you know, the power to change those things. So we have seen fewer arrests. And certainly the police department did less arresting, and that was a policy that was implemented during COVID. I think that has started to go back to regular levels now, unfortunately. But so we did see fewer people coming in, but not much decarceration here.
Thank you so much for sharing that. We're getting close to our time here, and I did want to wrap up with one final question that I'd actually like to tee up to you, Dr. Wurcel, but I did want to give a thanks to Drs. Ank Nijhawan as well as Dr. Simone Wiles for joining us today and being a part of our panel discussion. And there are multiple questions that did not get answered because of timing, so we'll make sure that, again, we compile those questions and we reach out to the panelists for today and make sure we get those responses for you all on the call. For our final question, what are some of the barriers that you've encountered in rolling out vaccines in the jails? And if we could start with Dr. Wurcel, that would be perfect. Thank you.
Yeah, I mean, I think the first barrier, well, you know, there's a structure of healthcare delivery that's pushed onto the structure of custodial care, and sometimes they mismatch or don't. I guess the biggest barrier, I think the biggest barrier was just knowing when the vaccines were going to arrive, and then the fact that there's a whole defrosting thing, and opening a vial means that you need to have a certain amount of people that are going to get a vaccine, and the actual coordination of it all. The coordination was the biggest barrier, but I was really impressed at how people came up with different strategies for doing that. And it was through partnership, like several calls with the Department of Public Health, that was able to happen. And then I guess the second barrier is the hesitancy or the mistrust, which is real and needs to be acknowledged. And you know, we definitely saw that there was more frequent uptake of the vaccine in white communities compared to Black and brown communities who are incarcerated. And so we went in actually with medical students, with doctors from those communities, with reverends who called out the historic injustices of Tuskegee, and said, our job here is not to make you do anything. Our job is to inform you, because in the past, people were not informed. And so I think that going in, the way we tried to get at the hesitancy, if you want to call it that, was just to say, ask me anything. So we've had about 20 ask me anything sessions in the Massachusetts jails. Ask me anything you want. I have no, and bringing people from the outside is super important. People who have no agenda in the jails, and even limiting the amount that the people who work in the jails can even enter and discuss during that sort of safe period where questions can happen. And then I think what happens is the healthcare workers who are in the jails are who everyone looks to for advice. And there is hesitancy in healthcare workers. I mean, I think we don't talk about it as much, but not everyone who's a nurse or a doctor wants this vaccine. There are people that are scared, just like everyone else. And so if the people who are in jail are sort of looking to them for advice, or even people looking to the COs, and the COs are saying, oh, I don't want to get it, that kind of messaging sort of often trickles to the people who are incarcerated. So I know when I go into jails and I say, you know, I'd love you to get the vaccine, and they say, have you gotten it? I say, yes, that's super powerful. So I guess my advice is to really make a culture in which it's accepting if people don't want the vaccine, but that there are people that have very strong opinions about vaccines. They're not all anti-vaxxers. I think there's people that hate vaccines, and they'll always hate vaccines, but there are people that are just concerned. So if you make a culture in which people can come to it in their own time, ask questions, then that would be my suggestion, and avoid shaming. So if we start saying, you're stupid, you don't want the vaccine, you're stupid, that really doesn't acknowledge all of the very smart reasons why people have concerns about the vaccine. So that's just been my experience, but I have to say, it's been going really well up in Massachusetts, really proud of it. And I'm excited for other people to be able to do this as well.
Thank you so much. It ultimately sounds like vaccine hesitancy has a scale, and depending on where those individuals fall, you can address that hesitancy with different interventions. Mm-hmm. For sharing that. Next slide, please, Aaliyah. Well, this is our concluding slide. Our next webinar, again, these are every fourth Thursday at 1 p.m. Our next one will be on March 25th, again at 1. We appreciate all the feedback that you all give us in between community of practice events, and especially during them, because that helps us, again, drive this forward even further. We will create updates for our toolkit. If you have not seen our toolkit, it is available at the link provided below, behavioralhealthjustice.wayne.edu/coronavirus. You can also go there to register for other events. And just in case you were not able to attend our December or our January community of practice event, the recordings and the slides are available on that website as well. We also are able to do peer facilitation and link you all to resources where needed. So again, please reach out to us if you have any questions. And last but certainly not least, please fill out the post-webinar survey. It's very brief, less than 10 minutes. We would appreciate that so much. Thank you. Next slide, please, Aaliyah. And here is the contact information for those of us at the Center for Behavioral Health and Justice if you have any further questions. Thank you all so much. For those of you experiencing snow in different ways, stay warm. For those of you in the sun, stay warm. Thank you and talk to you all soon.
Thank you so much.
Thank you for having me.